Hello, my name's James and I'm a patient representative with the Royal College of Psychiatrists. I contributed to the MEED guidelines and I'm trying to spread the word about them because I think from my own experience and knowing many other patients and carers, it's really difficult to get the care that you need in an emergency that could be life-threatening. And the most important thing about these guidelines is that they're used in practice. There are many things that you can do to help somebody with an eating disorder in an emergency setting, and they're not always that obvious because the patient might not look very unwell, they might not find it very easy to engage in their treatment, and all of these things and more I'll touch upon in this short, sweet presentation that hopefully gives you some tangible things to take away and put into your own practice. And eating disorders are something that are relevant to everybody in any role in healthcare, I think, because they are such multi-system conditions and they should be on our radar, whether or not somebody looks like they might have one, and there should be things that we can do to respond as well as to understand. I think that's very important. So here we go. I'll get moving. Haven't got very long. Take it seriously is the first thing. I think that's so important, and that people don't always look unwell. I'll give you an example from my own experience. I have recurrent very low potassium levels, which can affect my heart and is a real emergency. And I know all the symptoms that I have when that happens to me. And so I recently took myself to A&E with all of these symptoms, and knowing that I was kind of overdue a blood test and didn't have the up-to-date results. So when I went and said that I have this recurring issue and I've been admitted there in that unit before, I really struggled to be believed and taken seriously because I looked so well and I seemed so coherent and competent and calm as well. And they didn't perhaps take it seriously as they could or as they should have. And it was many hours later when they realized that I'd been sitting there with extremely low potassium at the level that was causing cardiac abnormalities. So I think remembering that eating disorders happen to anybody, not just this stereotypical image of young, white, middle-class females, for example, they happen across the age range and they're becoming increasingly atypical in their presentation, and that people can have, extreme signs of malnutrition on some parameters, an overweight status, for example. So bear that in mind. And that people might actually be finding it very difficult to engage in their treatment in an emergency, but appear to be absolutely fine, but underneath they could be really struggling. So taking it seriously, recognizing there are many sort of ways in which eating disorders can present that are all very serious. So considering the whole picture then is really important, because there might be things that you don't check because you think, oh, well, that person might not need them because they look fine, for example. And try not to be blinded, I'd say, by eating disorders themselves. Yes, it's great to have them on the radar and think eating disorders, yes, consider them, think about them and respond to them. But actually, I think sometimes that can blind us to other things that might be going on. So I've encountered that where people see eating disorder and don't think, well, what else might be going on in the body? And people say to me in A&E, oh, you've got to address the underlying problem, really, don't you? And yes, we can fix the potassium or the surface symptoms, but really, if you don't address the underlying problem that's in your head, then you won't change the situation and you'll keep coming back in and having emergency after emergency. But actually, what if the underlying problem is not just in somebody's head and it's physiological as well? And actually, many people have quite long-standing eating disorders, and these things are quite difficult to disentangle. When is it an eating disorder? When is it a bodily process? Or actually, is it a bit of both? Or is there a physiological thing that's maintaining the disorder? And the fact that I have gastroparesis, for example, with my stomach doesn't empty, which causes all kinds of problems, some of which can be emergencies. And this is just my own experience. That's because I have a genetic condition that wasn't picked up upon because all people saw was eating disorder. And actually, yes, that combination of the two means that both are really important, but that's what it's all about. It's about seeing this whole picture and seeing that it's integrated, not in little silos. And that's a real strength, I think, of what can happen in A&E, is that the whole picture can be considered. I think it's so important to ask questions and to listen and hear. Being really compassionate is so important. Not sort of skirting around difficult subjects, I think, is also really important, because people will probably, in some instances at least, want to tell you what's going on, but not know how to, or not feel that it's welcome, or be perhaps concerned that somebody won't understand what they say, or will be shocked about their behavior. And I'd encourage people to ask the difficult questions and to not be afraid of details, because if you don't know the details, or if you assume the details, then I think that it can be really difficult to actually get an accurate picture of what's going on for somebody. So I would encourage that too. And all your human, person-centered skills come into play there. Working with people is also important to that, working with patients and carers and showing them that you're on their side. That does start with the listening and asking questions and showing concern. And, if something sounds like it's a very difficult experience, saying that, or saying that you're sorry that somebody, is so unwell or in such distress or struggling to cope, and being very human about that, and not being afraid to be, because I think many people with eating disorders feel quite ashamed, as well as very fearful in an emergency, and they might feel very blamed. They might have had many experiences of being quite blamed, and carers as well, and actually treating that emergency as something that's, not their fault, and helping somebody to establish trust with you, for example, by doing what you say that you will do, so not promising anything that you can't do. All of these things are all very important to helping somebody feel like you're on their side. And you can have all the medical knowledge in the world, you can be an expert in eating disorders, but if the patient or and their family perhaps don't feel like you're on their side, then they might resist you putting that into practice to help them. And that is a barrier that's nothing to do with knowledge about the subject. It's to do with knowledge of how to get a good alliance with somebody. So helping somebody to stay and engage follows on from that. So we often say that people with eating disorders struggle to engage, or are resistant to treatment. And I don't think that's the case. I think that they find treatment very difficult sometimes, and that sometimes the treatment doesn't really engage them in ways that feel safe or work for them or respect their individual differences. So one of the difficulties I've had, which I think is important to mention, is the extreme end of engagement, I guess, is just staying in the vicinity of care at all and not discharging myself, because I find it very difficult with the environment, because I have autism and sensory differences and the change of routine. These are not uncommon in people with eating disorders to have co-occurring psychiatric conditions and neurodivergence. So thinking about these things and helping somebody to stay is so important. And I had a very good experience in A&E most recently, where I felt like there was a really good alliance, and I felt really listened to, really understood all of these things that I'm asking for. And then suddenly all the staff changed, and I didn't know when that was going to happen, and I didn't know what the plan was, and it was all new people. And I think that made it really difficult for me to feel like, oh no, all this sort of relationship that I built, which helped me to be here and made me feel comfortable to be here, has gone, and what's happening next, and what's the next thing. So something that helps me is knowing what's the next step, what's the next thing. And that might be different for different people, and I think it's important to ask people, what can we do that will help you to be here, and what can we do to make it easier for you to be here and to engage with this particular treatment, for example. I think that that's so important, and it takes the responsibility off the patient to be like, you must be here, and it's all your job to do that work, to be here. I think it's difficult enough for patients actually saying, what can we do to make it more engaging for you, to make it more accessible for you. I think those things are really important. So knowing your stuff, I've put as number 0, because it's kind of like we've got all these things that we should be doing, we should be thinking about in this emergency situation, but stepping back from that and stripping it back, all the way to the beginning, thinking about knowing your stuff. I mean, not just knowing your stuff about eating disorders and the subject and about the body and medicine and all this stuff. I mean, knowing your own personal stuff about how you feel about this is really important, because I think many clinicians are ambivalent or anxious about treating patients with eating disorders who might present with challenging behavior. That's something that I've done in the past because of not trusting, and I've got my eating disorder as a way of coping with difficult things, for example. That's quite a general way of putting it that I think applies to quite a lot of people. And here are these people trying to take it off me, and I'm going to kick and shout if I don't like that, or I'm just going to remove myself from the situation, or try to. And of course, that's a really difficult situation, especially for a clinician, especially when you're trying to manage really high risk, both psychologically, which we need to think about too, the mental state and risk of self-harm and suicide as well, but also, physiologically. So thinking about your own stuff and how you might feel anxious or how you might have certain ideas about patients with eating disorders that may not check out actually. I think that's a really important reflective practice, and being reflective and reflexive is so key. And actually bringing that to the interaction can really help build that sense of trust, because it's a very human thing when you hear somebody say, "Oh, I'm really worried about you, and I'm not," or sort of, I find that it's making me quite worried and anxious, that it's very high risk, and I don't want anything bad to happen to you. Like, this is a very basic thing that sometimes isn't said, and that I think is really worth thinking about in interactions with people with eating disorders, in terms of how can you build that alliance in a situation that's very difficult for everybody, including clinicians who might be very fearful, who might be anxious, or who might have some really unhelpful stereotypes. And I'm not, or assumptions about people with eating disorders. I'm not here to blame people or bash people, but I have had difficult experiences of care where people have responded to me in quite a stigmatizing way. And I think if those people perhaps examined what they were really thinking or feeling about me as a person, as somebody with an eating disorder, that's the kind of thing that I'm asking for, and being honest and having courage to approach and address the subjects around eating disorders, and to care for people with eating disorders rather than brush it off, because sometimes we don't consider things because they're just too difficult. And there are many people with eating disorders who don't have their eating disorder recognized as an important component, or they are in an emergency situation and they have certain things, and they look like somebody who doesn't have an eating disorder, although we know that's not a thing because anybody can. And if there's that little niggle of doubt, then go with it and have courage to ask, because it could be really opening a door for somebody. It could be really opening a pathway to treatment and to recovery and to health. So I think that's kind of one of the things that I mean as well. Don't just brush it off or just think, oh yeah, but they seem fine. No, it's fine. Because it may be, that reflective practice thing of, it's a really difficult thing for you or whatever, then that might help you to realize when that happens, if that makes sense. It's quite a convoluted way of saying it. So I hope that those things help, knowing your stuff. First and foremost, yes, theoretically, academically, clinically, but also personally, taking it seriously, thinking that people don't always look unwell, seeing the whole picture, thinking about comorbidity, co-occurring conditions, asking and listening, using your human skills, working with patients and their carers, and helping them to stay in treatment and to engage with that treatment that really, really does save lives, and really does sometimes act as a turning point in somebody's journey towards recovery and health, which I think is possible for anybody with an eating disorder, and often just as a result of a lack of timely care of good quality. So I hope that made sense. I'm sorry that I can't be there to present live. If you want to get in touch with me, then you can, and I'm happy to speak to any teams, to work with anybody or answer any questions. My Twitter handle is there. So I'll pass back to the rest of the presentation, and have a good rest of your day.